Today we are going to be discussing Chapter 11 in your book, which is Fluids and Irrigation Solutions. We will go through and we'll talk about some terms and abbreviations. We will also talk about fluid loss in the surgical patient, talk about electrolytes. We're also going to talk about some common IV solutions and their purposes in surgery. We'll talk about supplies you need for an IV line, talk about blood replacement, basic functions and types of blood, talk about some of the formed elements in blood. We will also talk about indications for blood replacement, some available options for doing so, talk about components of whole blood, autotransfusion, and then we will also talk about some volume expander solutions. And then we will talk about a couple other things as far as growth factors, oxygen therapeutics, fluids used as irrigation solutions, and equipment and supplies for all of these things. So first up, let's talk a little bit about fluid loss in the surgical patient. One of the primary goals of the surgical team is going to be maintain the patient and as stable of a physiological state as possible. You want to keep that patient kind of their baseline healthy. Hopefully they're healthy before they come to you in surgery. Fluids are going to be essential to anybody's survival, especially when you're talking about blood. And so replacing any blood that's lost, especially in large volumes, is going to be important. And fluids, these are two of the most common ways to maintain homeostasis. Also, keep in mind when we're talking about fluid replacement, the most common way to do this is just by administering intravenous or IV fluids and medications during surgery. Replacement fluids, these replenish the losses caused by hemorrhage in surgery. So if we're talking about blood loss here, and it can also be replacing fluids lost from vomiting and diarrhea, which this would be more done in the medical setting when you're replacing those fluids lost. Maintenance fluids, these just help sustain normal fluid and electrolyte balance in the body. Also keep in mind as a surgical technologist, you're going to observe blood and fluid loss and how things are replaced, and you might be assisting with irrigation during surgical procedures. So just maybe the surgeon might ask you to pour or irrigate some saline in the body, so you might be helping with that. And you'll see in this picture here, this is a surgery and they have an asepto syringe. It kind of looks like a turkey baster. So this might be used to specifically irrigate maybe smaller areas of the body during surgery. We're going to do a quick little review of physiology. Fluids in the body are going to be distributed between two distinct compartments, intracellular fluid and extracellular fluid. Also, the major electrolytes are sodium, chloride, potassium, calcium, phosphate, and magnesium. Other electrolytes in the body you might hear about too are bicarbonate sulfate and carbonic acid. Electrolytes have three main purposes. They're going to control the volume of body water by osmotic pressure. They also maintain the acid-base balance, and they serve as essential minerals in the body. In your book, you'll also see table 11.1. You can kind of break this down more if you want, but it'll show you the major electrolytes and their specific functions as well. Two electrolytes with particular importance to surgery are calcium and potassium. Calcium is the most abundant mineral in the body, and it's needed for healthy bones and teeth. You can see here the normal range is going to be 4.4 to 5.5. And also, I want you to be familiar with terms when we're talking about hypercalcemia and hypocalcemia. Think back to your med term days, and we've discussed this before with other body elements or ranges, I guess I should say, normal ranges in the body. Hyper is always going to mean too much, and hypo is too little. So that hypercalcemia is too much calcium, and hypocalcemia is going to be too little. Also, potassium is going to serve several critical functions in homeostasis as well. Too much potassium is hyperkalemia. Too little potassium is hypokalemia. Now make sure you're not getting these terms confused. They're very similar, so my suggestion is write them out and just memorize them, what means what. You might see that pop up later on a test. Okay, you guys are probably familiar with IVs. If you have ever had surgery or maybe been in the hospital for anything, they tend to almost always start an IV on these patients. These are given for two purposes. IVs are given. Remember, the patient's already going to be hypovolemic before surgery. Hypovolemic means they're going to have low volume of fluids. Why is this? I want you to put this in your discussion board for this week. The reason for being hypovolemic is a result of being NPO, or nothing by mouth, before surgery. If somebody's having a scheduled procedure, they will be told not to eat or drink anything at least 8 hours before surgery. We'll talk about this later. Mostly has to do with the risk of aspiration. If you have food in your stomach when they're intubating, there's a chance that that can come up, and then that causes an emergency. You can aspirate that and get it in your lungs. So these patients are going to be told not to eat or drink anything for a good while before surgery, so they're not going to have as many fluids circulating. So the IV helps to replenish those fluids in a safe way. You'll see here a picture. These are normal saline solutions. The 0.9% sodium chloride is referred to as normal saline. These can come in all different sizes of bags. They can come in just 100 milliliter bags, which are very small. You might also see 250 milliliters up to even 3-liter bags of these solutions. So they're available in a lot of different sizes. And just the big difference with these normal saline solutions is the volume that you have there. So a lot of times on total joint surgery, when they're doing a lot of irrigating because they've been cutting on bone and they want to get that bone dust out, they'll have a 3-liter bag hooked up to what's called a pulsivac, and that'll help to wash out anything, bone fragments or bone dust that are left behind. So they'll use a lot of irrigation. So they would like to use just a big bag instead of keep switching out smaller bags repeatedly. So these bags of sodium chloride, these are specifically used as just a fluid replacement and simple hydration for patients. So a lot of times, it's probably the most common fluid replacement used in surgery. It does not hemolyze or break up blood cells, so it could also be used in conjunction with blood replacement when you're giving blood products. There are also other concentrations you can see here, 5%, 3%, 0.45, 0.33, 0.225, but the most common one you're going to see is that 0.9 solution of sodium chloride, and it's just a 0.9 grams per 100 mLs is what that's referring to. Don't get caught up on the numbers, just normal saline. This will be a very common solution you will see in surgery. Dextrose is used in patients who need an easily metabolized calorie source. It's also available in various concentrations in water and also in normal saline. When the dextrose is mixed with water, it's used to hydrate patients, spare body proteins, and also helps enhance liver function. Dextrose 5% in normal saline, this is used for temporary treatment of circulatory insufficiency and shock from hypovolemia. What that means is there's not enough blood circulating. Maybe it's a big trauma. They've lost a lot of blood. They're going to give this, and it's going to help temporarily just get some fluid in there to circulate. Dextrose 10% in normal saline. This is used to replenish nutrients and electrolytes. There's also a number of other IV fluids available. Both 5% dextrose and ionosol B provide sources of water, electrolytes, and carbohydrates that'll cover hydration, water loss, and urinary excretion. Normisol and 5% dextrose injection. These are a solution of balanced electrolytes in water. It's used IV for parenteral replacement of loss of extracellular fluids. The Plasmolite and Isolite E, these are electrolyte balanced solutions. These help treat massive loss of water and electrolytes in patients that are having uncontrolled vomiting or diarrhea. You're not going to see these fluids here listed on this page nearly as much as you are the dextrose, saline, water, things like that, but just be familiar that these are available. And also I want you guys to keep in mind, typically it's the anesthesiologist is the one that will switch out these fluids, and they're the ones that decide if they want to switch to a different solution, what they want hanging on this patient on the IV pole to give them. So you're not going to be the one making this call, but just be familiar with the different types. So if an anesthesiologist asked you for a bag, you know that specifically what to go grab for them. They'll tell you exactly what they need, but just be aware there's different ones to choose from. Lactated ringer, this is also very commonly given in surgery. It's similar to Hartmann's solution, except for its ionic concentration. So you might hear these terms being used interchangeably, lactated ringer, Hartmann solution, same kind of thing. It is a physiological salt solution used to replenish the patient's electrolytes and rehydrate them to help stimulate renal activity, so keep those kidneys functioning. It's also used to replace fluid lost from burns or severe diarrhea. We definitely do not want to give this to patients who cannot metabolize lactate. Think about that. There's lactated ringer, so it's in the name. So if a patient cannot metabolize it, don't want to give them the solution. The patients that typically fall into this category are those with liver disease, Addison disease, severe pH imbalances, shock, or cardiac failure. Okay, so when we're talking about IVs and the equipment and supplies needed to start these, there's a couple things we want to have available. A lot of our patients in surgery will come to surgery with their IV already placed, so that's nice. A lot of times you don't have to take the time to do this in the OR. Sometimes though, maybe their IV isn't working well, or it's just a patient they have a really hard time getting an IV started on, and anesthesiologists are typically very good at this. So we might have to gather all these supplies so the anesthesiologist or nurse in the room can start an IV. We will not be, as a surgical tech, the one to do this, to actually start it, but it's always good to be helpful and know what supplies they're going to need. So first of all, a flexible catheter or angiocath is going to be inserted into the vein. It might be in the hand, forearm, if they have good veins there. Obviously, there's some people that are going to be more difficult to get an IV in, so they might have to go some different places to start those, but that's typically the hand or arm is where they're going to go. So on this picture here, the angiocaths are to the right of this little line I drew here. They come in different sizes, different gauges, just like hypodermic needles. They like to usually have a bigger one because some of the antibiotics they give can clump up that angiocath if it's too small. Also, it makes some of the medications that go into the IV more painful if it's a smaller lumen. So a bigger one is going to be more helpful. After that, they will connect the primary tubing, which you can see kind of this arrow here that I drew. That's going to be primary tubing. So it'll hook up to the end of the catheter, and the other one will hook up to an IV solution. Sometimes they will use secondary lines of tubing that'll hook up to this, and those will be used typically with antibiotics. We've talked a little bit, obviously about antibiotics, and they like to give these preoperatively before surgery. And just keep in mind the secondary tubing will hang higher on the IV pole than that primary tubing that is going to our fluid replacement. That way, gravity works for us, and it's going to infuse that antibiotic first. You can also see in this picture other items as well. Here, there's a tourniquet, this top right. You'll see, you want to wear your PPE gloves, tape to kind of secure everything, eyewear, keep your eyes protected. I'm going to have your red container to get rid of your sharps when you're done with the procedure, alcohol or a prep solution to clean off the skin before you insert that IV, going to have your fluid ready right there. So all different things that you would need to have available for that IV. I know our hospital has IV start kits, so it's going to have a little tourniquet, an alcohol, the dressing, tape, all of that in there, and then the doctor would just have to choose which catheter they want, so it makes it nice. And you can see here, this is basically just the setup where you can see that the hand has that angiocath, the IV in it, right here, and then you'll have your primary tubing, goes all the way up, and then you will have your bag of fluids here at the top. We're going to do a little bit of review on blood. So blood will perform several critical purposes in maintaining homeostasis in the body. If you remember back to your homework, the three main purposes are to transport oxygen, nutrients, waste, hormones, and enzymes throughout the body, maintain the body's acid-base balance, temperature, and water content, and it will carry the body's immune response. Blood volume varies with the patient's body size, how much adipose or fat tissue they have, and changes in fluid and electrolyte concentrations. The goal of blood replacement in scheduled procedures is just to maintain that circulating volume of blood. So if there's surgery that they know is going to be more high risk as far as losing blood, especially like a vascular case, they will typically go ahead and have that blood ready to go in the event that they need to give it and they're losing too much blood. I'm sure you guys are familiar with this. There are 4 different blood types, O, A, B, and AB. Any blood type can be Rh negative or Rh positive, and these are inherited. So this just means that you're going to get these, your specific blood type from your parents, a combination of theirs. In an average adult, the circulating blood volume is about 70 milliliters per kilogram of body mass. The amount of hemoglobin, which you remember back to your homework, that's the protein that transports oxygen and carbon dioxide between the lungs and cells. The hemoglobin will vary slightly between males and females. And then also age and gender both determine the normal levels of hematocrit, which is the volume of red blood cells in a given volume of blood. And here, these are the same numbers you guys wrote down for your homework question, but you can see them in a little chart what the normal blood range values are for these. Blood is going to consist of a couple different things, erythrocytes or red blood cells. These make up more than 99% of the body's formed elements. And then leukocytes are the white blood cells, help with immune response. Platelets, those mediate the clotting process. And then the fluid portion of blood is called plasma. You can see a little kind of picture here that sums it up kind of nicely for you too. Blood type is determined by proteins called antigens. So it's important that patients receive the type of blood that's compatible with what blood type they are. If type A blood is given to a type B patient, the recipient's antibodies will attack that donor blood. You'll have a bad reaction. So that's why they do blood cross-matching to make sure that the blood they are receiving is appropriate. And you can see here, if you want to look more into antigens and antibodies, I'm not going to test over this, but you can see who can give what type of blood to what patients, basically what's compatible with what. And you guys might have heard, universal recipients and universal donors as far as who can receive what blood. Type O can give to anybody. And then type AB, they can receive from anybody. This just shows you the antigens and antibodies on each type of blood here. So it shows you specifics a little bit more if you want to dive into that, but you don't have to. So indications, a couple things, why they might need blood in surgery. First up, hypovolemia. This just means that they have a low circulating blood volume. Most frequently, this is seen in trauma or vascular patients, people that have had a traumatic injury. Typically, you lose a lot of blood, whether it is a head injury, maybe they got in a car accident and they have damaged their spleen. There's going to be a lot of blood loss there as well. And then hypovolemia, the bad thing with this, it can be further complicated by anesthetic agents. These can also make the patient basically hemorrhage more. So that has to be kept in mind too. Blood replacement can also be given to restore the oxygen carrying capacity. So anemic patients, it's going to help with that. And also to maintain clotting properties. This is seen in hemophiliac patients. There are some different options for blood replacement. The most common one that you will see is going to be homologous donation. This is the use of donor blood. Sometimes patients can do what's called autologous donation. This is where they will donate their blood before a scheduled surgery, and then they'll be given that during surgery. And then unique kind of to surgery is autotransfusion. This is the patient's own blood being collected during surgery, and then it'll be given back to them either during the procedure or afterwards. Each different type of these is going to have its own advantages and disadvantages. You can see here in this picture, it is a unit of blood with a label. All donor blood is going to be tested for signs of syphilis, hepatitis, and exposure to human immunodeficiency virus before it's given to a patient. So it's going to be marked as safe as possible for people. And also right now, keep in mind when we're talking about this, right now there is such a shortage of blood because people are not donating. So I would encourage you, if you are able to donate blood, right now is a really great time to do so. A lot of places are putting on some mobile blood donation clinics just because, you know, there's not a lot of places with social distancing that people are getting together to do this, but there's still a critical need. So if you can donate blood, I encourage you to go out and do that. So next up, this one is whole blood. This is just one option for blood delivery. It's rarely used for transfusion today. It's going to contain basically everything that's in the blood. So nowadays we typically use packed cells. These are used for transfusions. And then platelets are administered in surgery when large amounts of donor blood have been given. This kind of helps to replace the volume. Cryoprecipitate is a plasma component used to treat hemophilia A, von Willebrand's disease, and a lack of factor 13. So a lot of times people aren't going to receive the whole blood, they're going to get some different type or component of blood. If you look this picture here, this is what's called a cell saver machine. Also in your textbook, figure 1118 will have it in there as well. These are used for autotransfusion. So it's used intraoperatively and post-op. It involves collecting the patient's blood, processing it, and re-infusing it into the patient. It's used a lot during open heart surgery, vascular procedures, some major orthopedic procedures, and some trauma. So with this, we'll have a special suction tip and suction tubing. Anytime there's a lot of blood, we use that specific suction to remove it, get it out of the way so we can see. Then we'll go back to a machine where it's processed, cleaned up, and then they will be able to give this back to the patient later. Another thing I want you to keep in mind with this, it says you can use it in some traumas. One specific instance where you don't want to use it in trauma is if there is bowel contamination. So what this just means is that maybe the colon, there has been some kind of perforation, so it's seeping poop basically into the abdominal cavity. You do not want to suction this up and put it in the line with going to the blood because you think how dirty that is, and it would just contaminate and it would cause a major sepsis. So you don't want to have any bowel contamination present if you're doing this autotransfusion. Volume expanders are used to increase the total volume of body fluids. They can be used when donated blood or autotransfusion isn't immediately available for emergency procedures. So if you have a patient that all of a sudden just starts bleeding like crazy and you were not expecting it, so you don't have blood in the room, the anesthesiologist might use these volume expanders to help until they can get blood to the OR. A lot of times albumin and plasma protein fraction, these are used to provide some volume expansion when crystalloid solutions are inadequate. And then also dextrin can help. It'll expand plasma volume by drawing fluid from the interstitial space into intravascular fluid space. So why we're concerned about this blood loss, if they don't have blood in their body, there's not going to be much of a blood pressure. They're not going to have that blood to pump. So that's why it's helpful to use these volume expanders just to temporarily get some fluid in there to keep pumping, help with that blood pressure. Het starch, this is given intravenously and it can expand blood volume by 1 to 2 times the amount infused. It's used for its osmotic properties and it is made from cornstarch. Growth factors, these are hormone-like substances produced by the body that can cause bone marrow to produce more blood cells. It's going to be used in the medical setting to boost red blood cells, white blood cells, and platelet counts. It's not going to work fast enough in surgery to do anything significant during that short amount of time. And these are not used in patients with severe bone marrow disease. Oxygen therapeutics are currently used in clinical trials. They are not approved yet by the FDA, but they're kind of being developed. So it's important that you guys have an idea of how donor blood replacement works in surgery. So the patient needs to be carefully monitored when they're receiving blood just for their own safety. There will be a requisition slip attached to the blood. So you have to properly identify the patient and verify the blood type. It will be refrigerated until use. A lot of times we have like a little red cooler that we have in surgery with ice, and that's what the surgery or the blood will be kept in until it's needed. And then it'll usually go through a warmer to get warmed up so it's not a shock to the patient and drop their body temperature. It can be verified by the circulator and anesthesia provider, and it's checked for clots, discoloration, leaks, or damage to the actual bag itself before it's given. So now we're going to talk a little bit about irrigation solutions. So before, when we're talking about fluid replacement, that's more of an IV that's given by the anesthesiologist. Irrigation solutions are going to be used at the surgical field. These can be used to clean the surgical field of active bleeding, improve visualization during procedures, as well as helping to distend some organs and abdomen for visualization too. There are many different types of irrigation solutions. So sodium chloride or normal saline is pretty much the irrigation solution of choice for open surgical procedures. It's sterile, topical, conductive, and it contains electrolytes. You never want to give this by parenteral injection. If it is systemically absorbed, it can result in alteration of cardiopulmonary function and renal function. So you will see this sometimes in bottles that can be poured onto the field and also in large bags that can be used for irrigation as well. Sterile water is another basic solution. It's used for rinsing and cooling instruments after they've been autoclaved. So after they've been sterilized, if they're still hot, you can always put them in water to help cool them off quicker. And also it can be used on cooling saw blades when drilling because they do generate a lot of heat when you're cutting through bone. You do not want to use this for irrigation and procedures using the cell saver machine we talked about a little bit ago. I want you to put this in your discussion board. Do not use sterile water in the cell saver machine. The big reason for this is when it's suctioned in there, it would hemolyze blood cells, and then those cannot be reused. Physiosol is a balanced electrolyte solution used a lot for sterile irrigation and washing and rinsing. It will provide good visualization during arthroscopy or when you're doing a scope on joints for orthopedic procedures. 3% sorbitol. This is another sterile, non-electrolytic, non-hemolytic, and electrically non-conductive irrigation solution. It's used for irrigation of the bladder or during what's called a TURP, T-U-R-P. You'll see it there on your slide. That means transurethral resection of the prostate. They can go in through the urethra and kind of shave the prostate down if it's really large, and also used for hysteroscopies. When we talk about it being non-conductive electrically, that just means it's not going to conduct that electricity. So when we are doing a procedure like a TURP, we're kind of burning out that tissue. So it's good because it's not going to conduct electricity. Glycine, 1.5%. It's sterile, non-conductive, and it's used to irrigate body cavities. It can also be used in TURPs and hysteroscopies. Hyscon is a 32% solution of dextran 70 suspended in glucose. I've not actually ever seen this used, but it can be used in their uterus during hysteroscopy and used to irrigate blood and tissue debris from the surgical site. Viscoseal. This is a synovial fluid replacement solution. It's going to be used to irrigate joints, and it can substitute for synovial fluid. So there's different supplies that you will need when you're irrigating. It depends a lot of times on how big the surgical site is, what you're going to use. Something small like a hand, you might just use a regular syringe to irrigate that out. If you're doing something a little bit larger, maybe like a foot, something like that, you can use the Asepto listed or shown right here. Toomey syringes, this bottom left, these are going to be used in the bladder. They can hook up to a Foley or a sheath to irrigate the bladder out, especially if there's a clot in there. Sometimes you'll have people that have bladders that bleed after the procedure. The Toomey can be used to irrigate that out. And then the Elic evacuator, this one's pretty unique. The bottom right, this is used a lot of times to irrigate prostate tissue out when you've done a TURP. Sometimes you will see in a large abdominal procedure, they're just going to use like a pitcher, a sterile pitcher, and they're just going to pour irrigation solution in like that too. On my slide, it's kind of hard to see on this one, but it says irrigation supplies and equipment continue. Continuous irrigation is just a closed disposable system. So it'll have one end that hooks up to a bag of fluid. The specific one, another end will hook up to a suction machine. And then you will have this portion, this long barrel here. This is what we can use in endoscopic procedures through a port. So if we're doing a laparoscopic procedure with little tiny ports, this can go in and irrigate, and then you can also suction it out too. It's called a suction irrigator. There also are some pump systems available to supply more fluid under pressure, so especially arthroscopies when you're doing a surgery scope on a joint. Okay, we're going to skim over this page. I'm not too worried about osmosis. It is important though, patients' blood and fluid balance, you need to keep in mind that this kind of starts preoperatively to see where they're at. you're going to monitor them intraoperatively. Sometimes when patients are bleeding a lot, like I mentioned unexpectedly, you're going to want to get some blood in them quickly. IV sites and complications. Let's focus on this a little bit. So we can give fluids to the patient through a peripheral line, like in a vein, arm, or scalp. Typically that's reserved for infants. So they can also be given through a central line with a special catheter that's in a large vein. The complications of IVs can include phlebitis, infiltration, and infection at the site. So a lot of times if these patients, once they're not needing to give fluids through these sites, they will try to get rid of the IV just so it's not a breeding ground for infection. And then there's two types of irrigation, continuous and intermittent. So continuous just means that this is going to be performed to replace and maintain fluids in the body. It'll be given continuously. And intermittent means fluids instilled into an area of the body through a steady flow. Okay. If you guys have any questions, feel free to post those on discussion boards. Otherwise, have a great day.